okay in the back? All right, very good. Thank you for the very warm introduction, Tina Marie. Appreciate it. So my topic today, therapeutic scuba diving, deliberately named Exploring the Shallows of the Scientific Literature. There is very little on the scientific literature, and I'm going to present what is out there in sort of the peer-reviewed literature, talk about some medical topics specifically to scuba diving and rehabilitation, as well as talk about some potential opportunities and really sort of the vastness of potential opportunities for research into the future. Just a little bit more on my background, as Tina Marie had said. So it's interesting, I actually had gotten involved in scuba diving much before my medical career, ended up getting more advanced in scuba diving, became a rescue diver. Subsequently, after my medical training, really felt this attraction towards the impaired and disabled type populations, and that was eventually what I ended up choosing as my career. And now it seems to be coming kind of full circle as I move forward. So it's very exciting. So as I said, I'll talk a little bit about sort of the emergence of scuba diving, at least from the scientific perspective and the literature perspective. Expand on some medical topics. Feel free, if people do have questions as I'm going through some of these topics, if you want to raise a hand, it's fine. We can veer off a little bit to ask questions, or you can save them for the end. It's fine with me, whatever you would like. Talk about, as I said, the benefits and benefits that are out there in the literature, and talk about sort of the future. So scuba diving is a very technical sport, as I imagine most, if not everybody in here, recognizes. Equipment is very important, but then once you start working with populations that have physical impairments, psychological impairments, there may be other types of equipment that are needed, and so there's been an emergence of adaptive equipment. By no means is this an all-inclusive type of slide, but just shows really different types of things. Gloves with webbing, different buoyancy control devices that can help support the lower limbs, motorized devices that can be held underwater. There's all sorts of different things that have been developed and evolving over time to help the adaptive scuba population. So going back into the 70s is really where I could find kind of the earliest literature that talks about scuba diving. And so there was a training course actually for paraplegics as well as bilateral leg amputees. Anything from what they say T4, T6, T12, and L3 spinal cord injuries, which is referring to the thoracic level or the lumbar spine level as far as the spinal cord injury, and basically saw that all of these people with disabilities were able to master all of the techniques, with the exception of the T4 spinal cord injury patient, which means thoracic level 4, which is essentially up to this level here. And the major reason that they had issues was actually respiratory. They just had trouble sort of expanding their lungs, breathing. So this is the person that had the most trouble back in 1974. Moving forward, 1981, the Handicap Scuba Association was founded. Welcome to have lots of HSA people here. I didn't realize you guys were going to be here. This is fantastic. 1984, the next paper that I was able to find, there was a training course for those with traumatic brain injury. Really sort of the first course that really delved into this, and an interesting population to work with, which we will expand on a little bit later. And then in 1988, there was a case report that was published for a T10 paraplegic, and it was a very interesting title, sort of scuba diving, taking the wheelchair out of rehab sports. So there's just sort of a heartwarming type of paper that was out there as well, and numerous papers that have subsequently been published, but still relatively thin. So with the emergence of adaptive scuba, recreational scuba, things of that nature, those with physical impairments, disabilities, etc., started to notice certain benefits that were coming out after the scuba diving. The traumatic brain injury patients, stroke patients, spinal cord injury, chronic pain, autism, post-traumatic stress disorder, those with spasticity, spina bifida, and cerebral palsy. All of these seem to this is not an inclusive list, by the way, but in the lay literature, on the internet, things of that nature, you're going to see people that anecdotally report many benefits from scuba diving specifically. And with that was a growing number of adaptive dive organizations. Anything from local, national, international level. Military has a whole host of different programs that are involved. Private organizations, public, nonprofit organizations, there's a whole host, and the list is only continuing to grow. I was trying to do the research to actually find sort of the number of organizations, and it's so vast that there's nobody that really is able to actually quantify that more specifically. So some specific medical topics that I want to go through sort of before we get into the research. Hyperbaria and sort of the physiology that can be involved with hyperbaria or going to depth. Pulmonary function, spasticity, motor function and ambulation, as well as pain. So as you enter your basics of scuba diving, there's sort of the physics, and it's the ideal gas law. So I don't want everybody to get like too bound up here, but I have a kind of a graphic that can help to explain this. But pressure times volume on the left side of the equation equals the number of gas molecules times a constant times the temperature. And so that's sort of a concept that we're gonna go through right now. So I have a little schematic here. Can you guys see that? It's sort of a seascape with a balloon on the top. You guys see that? So taking into account this idea, as you move down in depth every 33 feet, you go to another higher level of pressure, such as it's increasing incrementally up to 4 atmospheres when you get to 99 feet. Okay? So taking this concept, if you have a balloon at the surface, okay, and you start to increase the pressure, right? So we're talking about you go down in depth, well, something within this formula has to change. So what happens is we keep the number of gas molecules, that N, the same. The constant is a constant, so that stays the same. And assuming same temperature, something has to change, and that's volume, because it's a closed system. So as you go down in depth, the balloon gets smaller and smaller. You know, relatively easy concept. Now, you think about, okay, you take a pair of lungs, which is what the other graphic is there, okay? So now with scuba diving, it's not a closed system anymore. You're breathing throughout this, so you're getting gas exchange. So now the N is no longer constant, and so we're going to see as you go down in depth, the pressure will increase. Now the volume is going to remain the same. That volume is remaining constant because you're still filling to the capacity of your lungs, but what changes is that N, the total number of gas particles that you're inhaling. So as you continue to do that, the lungs stay the same size, of course, and the total number of gas particles that you're inspiring increases. Okay? So putting that into a graphical form, think about it as partial pressure. So partial pressure of oxygen, partial pressure of nitrogen. Two sort of basic concepts as you go through your scuba diving. As you increase in pressure, right, that partial pressure will increase. So the partial pressure of oxygen at the surface, 0.21 or 21%. Partial pressure of nitrogen, 0.79, 79%. Every atmosphere that you go down, that increases. And I want to point out, so the partial pressure of oxygen at 21%, when you get to 99 feet, it's 0.84 as the partial pressure. Okay? So something to keep in mind. All right. So now thinking about expanding onto that hyperbaric oxygen therapy. So we've just gone through how with scuba diving you're inspiring increased oxygen. Well, they also have chambers, surface level chambers, where you basically breathe 100% oxygen, but they increase the pressure within there to mimic essentially what's happening with that with the scuba diver going to depth. And so the idea is, and I have on here, there's the pressure must equal at least 1.4 atmospheres, so significantly less than even going to that 100 feet. But now you've increased, instead of that 0.21 or 21% oxygen, now you're at 100%. So even what I just showed, go back one slide. At the bottom here, that 0.84 at 99 feet, already at the surface, we're already above that as far as the total amount of oxygen. So now you increase the pressure, now you're absorbing even more oxygen into the body. And there's a lot of proposed and benefits with that. allows greater absorption of oxygen throughout all of the body tissues. Okay? There's numerous indications that are FDA approved. There's a whole host of things that are not. We're going to kind of get into that, but most of these aren't necessarily topics that we're thinking of. Really severe infections, osteomyelitis, necrotizing tissue infections, burn injuries, intracranial abscesses, anemia, a lot of potentially chronic diseases, but not necessarily the populations that we're thinking of. What is on here, you'll notice, decompression sickness, so something that we oftentimes think about. Air or gas embolism, increase the pressure to help bring that gas embolism to a smaller volume. And then, yes. So interestingly, there's a little bit of a controversy with hyperbaric oxygen, and I just wanted to kind of bring that out. If you look on the internet, you look out there, even different environmental chambers, they're still a business. They're trying to bring in money. And there is a lot of anecdotal evidence, particularly from the scuba literature, et cetera, that shows benefits of hyperbaric therapy. So I have a whole bunch of lists over here. It may even be a little small, and I apologize for that. But Alzheimer's disease, asthma, brain injury, cerebral palsy, hepatitis, migraines, Parkinson's disease, spinal cord injuries, stroke, sports injuries. All of these are what are considered off-label treatments. The FDA has not necessarily said, yes, these are approved treatments, but there's reason to believe, and these are certainly offered out there as hyperbaric oxygen for treatments of these. Why it's become a little bit of a controversy is the FDA actually came out with a consumer update. And this is actually a flyer that the FDA has put out, basically saying the safety and effectiveness of hyperbaric oxygen therapy has not been established for any diseases that are not on the prior list. So it's just a little bit of maybe some misleading claims out there. So I just want everyone to be aware when we're talking about hyperbaric oxygen therapy.
Doctor, I'm sorry.
Yes, please.
Can I add to that?
Absolutely, please.
Because we get calls a lot at Dan about that. Quite often, what you're referring to, legitimate hyperbaric oxygen therapy, yes, there's a lot of benefit to that. But unfortunately, you have these individual spas that have essentially like a vinyl balloon or bag that they can put people in, and they're not breathing oxygen. They're breathing nothing but room air. That's it. And they're in the equivalent of about 9 feet of water. So be very careful, like the doctor said, be very careful about who you talk to about those treatments and ask them exactly the specifics on it. What are you offering? Yes, sir.
I would agree with that too. As someone who did hyperbaric oxygen therapy as a person with autism, what made it work was having had that experience for 2.5 years, going under 10 feet of water, doing submerged victim modeling for the Red Cross. I was able to acclimate my body to the pressure that was in the chamber that helped me physiologically. But what I realized is that I'm getting this benefit because of that background I had 2.5 years ago and that consciousness, whereas I'll bet some other people with disabilities might not be able to acclimate themselves to the chamber.
Exactly.
That was a conclusion that I made, so just to support what you said.
No, thank you. Yeah. Sorry, Dan.
Could you really quickly summarize with the video both of those thoughts?
Absolutely. Absolutely, sure. So interestingly, we have two people here who have some knowledge on this. One who's personally experienced it himself and received benefit from that. Very interesting. Thank you for sharing that. We do appreciate that. And another who works for Dan, who is talking about they frequently get calls to say, what can we do, and commenting specifically to the fact that there's a lot of, or there's little regulation out there with some of these chambers, okay? And so someone who may be going to receive the benefit of a chamber, first of all, may not even be truly receiving what has been shown to be beneficial. And secondary to that, what I was more specific to what I had initially talked about was that the FDA, their claims that this is beneficial, and certainly anecdotally that there is, and I'm not saying by any means that there isn't for any of these populations that are used for off-label treatments. The literature and the FDA just doesn't have enough evidence on that right now. Okay? Yeah, thank you. All right. So moving on, just to talk a little bit about pulmonary function. There's a primary way to measure pulmonary function. It's called spirometry. maybe some of you have done that or you've seen that, but you essentially breathe into a device. It measures the volumes. We're doing okay?
No, I said that's what we want to do.
Okay. Oh, yeah. It really can look at the pressures, gas exchange. It really gives you a whole host of different pulmonary parameters, particularly for those who've had a stroke or spinal cord injury, brain injury. Those who have a type of neurologic injury specifically is going to affect different musculature that affects pulmonary function. There was some research in 2009, very nice study. So they saw that there was decreased chest wall and lung compliance for those with tetraplegia, meaning essentially a spinal cord injury from the neck down, or what we commonly think of as quadriplegia. Increased abdominal wall compliance, meaning that when you take a breath, normally your abdomen, your belly maintains a contraction. But if you've lost control of that and you try to inhale, your lungs oftentimes in a normal state rely on that contraction to maintain good pulmonary function. So meaning that your abdomen may distend, your lungs may not be able to inhale properly. Rib cage stiffness and what they call paradoxical chest wall movements. And they did see, it was those that were more severely affected, they did test some paraplegics as well. The paraplegics, high paraplegics, had similar problems, even though their cervical spine and upper limbs may not have been specifically affected. I put a slide in here. I don't want anybody to get bogged down with this, but these are some of the reports, or at least some graphical depictions of what you may see. On the left here, when they do the report, it's called a volume flow loop. And so there are different ways that you can potentially assess someone's pulmonary function. You can assess for COPD, restrictive type lung diseases, combination diseases, things of that nature. On the right is a graphical depiction that I would like to maybe point out a little more specifically. You see this sort of sinusoidal wave, or this wave. The sort of narrow band there, that's what most people are sort of breathing at a regular state. As you just sort of breathe, you're not even thinking about it. They call that tidal volume. So it's a small amount, as you can imagine, of the total lung capacity. Okay? So now, if you take a maximal inspiration, meaning you just breathe in as hard and as fast and as long as you can to fill up your lungs, that's now going to be the top of this chart, maximal inspiration. And then if you blow out all of that air from your lungs as much as you possibly can, there's still some airspace within the lungs that is not quite getting emptied. Okay? And so we call that max expiration. That total volume, so the max inspiration to the max expiration, so this sort of area here, that's called the vital capacity. Okay? And so there is a lot of research that has pointed to vital capacity. Instead of having to do this whole extensive pulmonary testing, if you test this one thing, you test vital capacity, particularly for those with a spinal cord injury, it seems to correlate quite linearly with those with spinal cord injury and their pulmonary function. Okay? All right, the next topic is spasticity. There's a great quote here that has really been referenced ever since 1980 when it first came out. I'm going to read that for you. Spasticity is a motor disorder characterized by a velocity-dependent increase in tonic stretch reflexes or muscle tone with exaggerated tendon jerks resulting from hyperexcitability of the stretch reflexes as one component of the upper motor neuron syndrome. So a lot of fancy words there. Basically, the idea is anytime you move a muscle, there's a signal that comes from your brain, goes down to the base of your brain, through the spinal cord, out through the spinal cord, into your muscles, okay? That motion. Well, there's also, that's what you would call an excitatory signal. A signal that goes down, you tell the muscle to move, the muscle moves. There's also signals that come down from the brain that are inhibitory, that actually help to dampen that, so you are able to have much better control of that. There are also reflexes that come back from the muscle to the spinal cord and back out. And what happens is in spinal cord injury, brain injury, or stroke, that inhibition, that descending inhibition that I talked about is removed. So they get increased tone, they get increased reflexes, spasms, things of that nature. It can be quite debilitating and painful. There's a sort of a classic posture that you may see, particularly in stroke patients. Someone who's had a stroke, their arm is often internally rotated, adducted, They have their elbow flexed and their wrist flexed. Maybe you see this. That's a component of spasticity that we would call, okay? We call that a flexion type posture, okay? Upper motor neuron syndrome. So basically a damage to the spinal cord or the brain that inhibits that descending signal. Pathologic reflexes, so they're going to have increased reflexes, increased tone and spasticity, as I mentioned. They also may have low tone or high tone, depending on where the injury is and where some of the specifics that may have been affected. And they're also going to have oftentimes weakness or reduced motor control and coordination by virtue of that, okay? And then gait. So gait is a term that we use for walking, okay? It's a pattern of movement as we move ourselves forward. So it's a rhythmic type of motion. There's a lot of coordination, as you can imagine, between the different muscles, particularly of your lower extremities. You're shifting your center of mass both to the left and right, but also moving your center of mass forward, okay? It's under a complex neurological control. Your brain is sending signals down to the spinal cord. The spinal cord is interpreting some of those and sending signals out to the muscles. And then there's also signals coming back from the muscles back to the spinal cord that are helping with reflexes to help provide sensation and modulation of your walking. Okay? A very complex system. There's lots of research out there. Here's sort of a sample. You can see this person walking, but there's very defined time points within a normal gait cycle. And for those who have had some type of brain injury, stroke, spinal cord injury, this is affected, and their walking mechanics, their pattern of gait is now altered from what it would have been previous, or to say a normal or even a premorbid condition prior to their injury. There's this idea that the spinal cord has what they call central pattern generators. Nobody's quite sure of this, but basically the idea has come about when they've done spinal cord injuries. They've induced spinal cord injuries on animals, cats, rodents, whatever it may be, and they put them on a treadmill with certain stimulation factors. They are actually able to move their limbs, not quite the same as it would be with a normal gait, but that's led to a whole host over decades of these things, of this idea of a central pattern generator, okay? So it's basically taking, the spinal cord, yes, is receiving signals from the brain, from up above. It's receiving those signals from the periphery, the muscles, the skin, the joints. To try to do that, the idea is now, and this is a very sort of rudimentary picture to explain this, but it's basically taking the motion of the ankle. And so you have both flexion and extension of the ankle. So flexion being bringing your toes up, extension pointing your toes down. So think about those as alternating movements. And so now, on the left is sort of a schematic. There's this, F and E, so flexion and extension, what they're calling the central pattern generator. If you sever above that, if you cut off the spinal cord above that, is there something that can be stimulated within these central pattern generators to help someone with mobility despite having a spinal cord injury? So there's a lot of theory out there. Some people that do this type of research don't believe in central pattern generators, some do, but they all agree, there's no question about it, that the data shows with certain factors that they are able to reproduce some of that pattern of gait. There's just disagreement about what's actually going on there. Okay? So we're gonna revisit that in a little bit, but I wanted to introduce that idea. So sensory pathways, specifically talking about pain. There are multiple different sensory pathways that go back from the periphery up to the brain and how you sort of receive that. I apologize for, maybe it's a little too small, but I'm going to demonstrate. So over here, we're going to have what we'll call a noxious stimulus, a fire, a hammer. There's a signal that comes back through what we call a C fiber or an A delta fiber that goes back through the spinal cord, back up to the brain, and is received as pain. Well, there are other sensory signals, non-noxious or non-painful sensors that also go back, and those are through the A beta fibers. So key thing that we're going to talk about is that those fibers, they travel back up through the spinal cord, they go to a sort of a sensory relay in the brain called the thalamus, and then it gets dispersed to the cortex of the brain, which is where you actually perceive those pain signals or those sensory signals, okay? But also one thing that's important to point out, pain is a highly complex and subjective experience. It's not just you feel that pain, there's an emotional response to that. It's a whole type of experience, and people respond to painful stimuli very differently. I have this what they call a functional MRI up here, and it's showing that someone giving a painful stimulus, you can see these orange signals sort of lighting up all over the brain. Yes, they're lighting up right where that sensory part of the cortex is on your brain, but they're also lighting up in all sorts of other areas for how the brain is responding to that. Okay? And so your body has lots of ways to modulate pain as well, and I promise this is the last slide on kind of going through all of this pain, okay? But up on the upper left here, you see this idea back from the 16th century. There's this drawing, a person touched the fire, the signal, just as I mentioned, went up to their brain, and they felt that sensation. Well, now there's much more understanding of that. We're now looking into the 21st century. Your emotional state can play a role in that. There's lots of signals that can modulate that within the spinal cord, within the periphery, chronic pain versus acute pain. There's all sorts of different things that can happen within the body, and even transitioning from acute pain to chronic type pain, and there's even different types of pain. So there's just a whole body of evidence of literature out there, and it's still in the works. There are different medications, lots of things that are being done. This drawing on the right, I'm not going to talk specifically about that, but that's just showing that there are both inhibitory and excitatory pathways all to modulate painful stimuli. Okay. That's all I have on sort of the medical topics. I'm going to go into some of the research right now. Does anybody have any questions in particular about some of those medical topics that I went through? Okay, very good. All right. One key thing I want to point out is there's very little research out there in the peer-reviewed realm as far as scientific literature. There's a lot of anecdotal evidence, there's case reports, but there's just really not a whole lot out there. I've sifted through what is out there, and I'm going to present that today. I will, for the most part, point out when things have been peer-reviewed, and then I've sort of separated them into sections for those that are more anecdotal, case reports, unpublished data that are out there in the literature, okay? Let's see. And that is peer-reviewed, a lot of it, I'll say, is sort of mixed quality, okay? So the psychosocial benefits of scuba. This is probably the most published, and all of these papers, all of these topics here essentially have been validated and have been presented in the peer-reviewed realm. So increased self-confidence, better community integration among disabled divers, emotional well-being, quality of life, improved self-concept, and adaptive behaviors among the disabled or physically impaired divers, increased social participation, self-concept, sense of freedom for those with autism spectrum disorders, improve post-traumatic stress disorder symptoms. So these are all out there and have been, there are even more articles than this, but this is one area that there's certainly room for more research, but this is, of the topics out there, this has been the most studied. Physiologic benefits. Reduced spasticity. So there are multiple studies, again, not published necessarily, or maybe case reports, or even just abstracts that have been published to demonstrate that there's reduced spasticity among those with paraplegia. Okay? Increased pulmonary vital capacity. So as I mentioned with the whole graph, the one area that I pointed out, that vital capacity, that seems to be the one measure that if you were to take one measure of all of that, again, it seems to have a direct correlation with pulmonary function. And so they're seeing an increase in vital capacity, which is a positive thing for those who are doing paraplegics with scuba diving. Improved motor function. So improved actual movement, volitional movement is what they're seeing, as well as improved sensory perception. So similarly with stroke, spinal cord injury, brain injury, not only are you knocking out those motor fibers, but you're also affecting those sensory fibers. And so they're seeing improvement within sensation as well, okay? Again, these I think one of these papers for reduced spasticity is in the peer-reviewed realm. Okay? Yes, please.
When the studies that were done on these divers, were these open water dives or were these dry dives in a chamber?
I believe that they were mixed. Definitely some of them were open water dives. Again, and why I say it's mixed quality or even low quality, there's no controls. Right. It's, a lot of it is based on subjective measures, but not using a true control population to really drive that out. But yeah, absolutely. It's mixed. Mm-hmm. Please.
Kaplan took 13 vets down to Cayman, so that his study was open water stuff. So maybe you can paraphrase that.
Absolutely, sure. So yes, one of the papers on here, this Kaplan paper from 2013, they took a group of divers down to, where was it? To the Cayman Islands. Really, and forgive me, I don't know all the specific details of it, but a lot of this is on here. So they were paraplegics. They did see improved sensation, motor function. A lot of these were from that data. Most of it I had to pull from, so he did his research. It's posted on Johns Hopkins, but it's mostly through the website. It has not made its way necessarily to the peer-reviewed realm at this point. Sir?
13 subjects called the Cousy study, or help me out, Jeff. Trouble is, he didn't publish any of the data. We'll talk about that a little bit in my presentation.
Excellent.
But they went down there, they did a lot of work. I could probably just speculate why, because 13 is not a large enough sample size to create data. That would be my guess.
And again, they had no control population as well to compare against. So right, I don't know if they're planning on making it, submitting for journal publication or something of that nature. I don't know at this point. There was another question. Yes, sir.
In reducing the spasticity, is there any information in the study which gives the mechanism by which the spasticity was improved? Was it the pressure, the hyperbaric pressure of being in the water, or was it a combination of the temperature and the the variables are there? Do we know what it was, or how can we attribute the benefit? What can we attribute the benefit to in terms of reducing spasticity?
That's a great point, actually, which actually is a nice segue. So part of his question is, what is that benefit from? And nobody quite knows. And part of the idea that I want to introduce today is it's a multifactorial. There's numerous factors, and I try to break down the benefit of many of those factors that may be involved in scuba diving. Is it additive? Is it multiplicative? Nobody quite knows. And because they haven't published it, they didn't necessarily try to make claims on that. But I certainly will make some speculations today on some of that. Right, and you can't deny that. You can't deny it. But right, I'm a scientist, a physician. I'm here to publish what's out there in the literature. But I believe in it. I do.
Yeah.
Exactly.
Right.
Yeah. Well, somebody here might be taking donations. All right. So I have a little schematic here to talk about some of those things that may be part of this. Physical activity itself has proven to be beneficial. Three-dimensional movement, right? Taking someone who may be very limited mobility on land, you put them in water, they're much more free to move around. The camaraderie and teamwork. There's a whole team building kind of association with that can be beneficial. There's a meditative sort of component to this with meditative breathing. Hyperbaria and compression specifically, we'll talk about that particularly with pain, but I think there is some component with spasticity. Aquatherapy itself has been shown to be beneficial, and then something a little more technical is what I say chemical induction. So with those increased partial pressure of gases, are there induction of certain chemicals within the brain or spinal cord that may be providing some of the benefit as well? So aquatherapy, there's data to demonstrate that aquatherapy in many realms is beneficial for those with disabilities. I'm not even going to go into that because it's well established. Okay, physical activity has been shown to be beneficial for those with disabilities, shown over and over again many times. As I mentioned, this sort of idea of three-dimensional space, moving through a gravity-free environment, a lot of these psychosocial papers that I commented on, some of them talk about, being free of being able to move through space, sort of free of the wheelchair or their physical limitations. So pressure and compression has sort of a broad spectrum to it. The compression for those with edema or cardiovascular disease, or those with a spinal cord injury who have low tone in their muscles, they may get venous pooling, they may be prone to clots, lymphedema. Increasing that pressure may help to, or there's no reason you wouldn't expect it to help increase blood flow back to the body. Mechanical reduction of pain. I'm going to get into some more specifics about that by putting compression on those, stimulating more of those mechanical receptors to try to help reduce or inhibit some of those painful stimuli. Let's see. Okay. So as I mentioned, chemical induction. So serotonin is one of those chemicals that has been studied. So they did see in the deep structures of the rat brain, they did see with scuba diving, they saw, or increased hyperbaria, they did see increased serotonin in some specific locations. So the striatum, which is part of the basal ganglia, which is one of the areas that can potentially be, or that is affected in Parkinson's disease. But so they're seeing increased serotonin there. And then also there's medications out there, an antidepressant are called selective serotonin reuptake inhibitors. So you start to create more serotonin, are you potentially helping to elevate that person's mood? Okay, and then also serotonin has also been implicated as some of the inhibitory pathways or modulatory pathways for pain signaling. So if you can have this induction of serotonin purely by going down underwater, there's multiple effects from serotonin. And then it's also been seen in central pattern generators, specifically going to a study. I point one out in 2011 using both invertebrates as well as rodents. They did see that serotonin is implicated in those central pattern generators. And even among those, and the research out there of those who don't necessarily believe in the idea of central pattern generator, when they are stimulating an injured spinal cord on an animal model, they're almost always putting in serotonin. They're infusing serotonin into the spinal cord as well as potentially other chemicals such as glutamate. But serotonin is almost exclusively involved. Okay, so now talking a little bit more about pain. You may have heard of the gate theory of pain. I see our nurse in the audience nodding her head, yes. So the gate theory is, generally speaking, the way it kind of came about is if you think about a gate, a fence and a gate, you can only fit so many things through that gate at one time, right? So the idea is if you have all of these pain signals coming back through the spinal cord, many of them are pain or you have painful signals coming through, if you can introduce other signals that will then take precedence over those pain signals, you may have a reduced sensation of pain. And so the idea is that those A delta fibers, which is the sort of non-noxious or the mechanical stimulation, that there may be some other neurons, branches off of those, what they call interneurons, that are inhibiting those A beta nerve fibers to potentially help reduce that signal of pain getting back. So it's an interesting concept. This similarly, pain can lead to worsening spasticity. So by treating pain, you're potentially helping to treat spasticity. And spasticity, at least part of it, also has to do with the reflex arc. So if there are more inhibitory neurons being stimulated within the spinal cord, are you potentially helping to inhibit some of that spasticity? All right. Hyperbaric oxygen has actually been studied quite a bit in animal models. They did sciatic nerve injury in rats. There are multiple studies looking at different chemical factors. They did see what they call anti-nociceptive. Nociceptors are pain type receptors. So inhibition of those pain receptors in rats, as well as another factor called TNF-alpha, which is also a chemical signal that's involved in pain. So rats that were induced a sciatic nerve injury and then given hyperbaric oxygen had a reduction in that pain. And I don't do a lot of studies on rats, but there was very specific things that they looked at that were validated to determine that these rats were having less pain. It was not a survey or something that they would fill out. Okay, there were other behavioral factors that they would look at for these rats. They also did a spinal cord injury in rats, particularly at the L5 level or the fifth lumbar level, and they did see specifically that there was a reduction in pain and mechanical sensitivity. Trigeminal neuralgia, which is a nerve that does affect the face. It's a very painful type of stimulus that people are getting, and they've actually seen these in humans and animals. Hyperbaric oxygen seems to be neuroprotective, anti-inflammatory, and it also potentially inhibits further nerve injury, depending on the time at which it was given to onset of symptoms or induced injury in animal models. And then there's also apoptosis of different cell lines within the spinal cord were induced with injury. This seemed to help prevent apoptosis. Apoptosis is a programmed cell death. So certain cells within the spinal cord were dying, or at least a chemical pathway triggered them to die, and for whatever reason, for whatever reason, this hyperbaric oxygen helped to prevent that. So getting back to our earlier point is that looking at all of these factors, kind of breaking them down, we know that physical activity is good for these people. Moving through a 3D environment is beneficial. Talked about certain populations where hyperbaric oxygen therapy is beneficial. You're taking all of these individual factors that seem to be beneficial, and now you're putting them all together with scuba diving. There's not really a way to quantify it, at least certainly not yet. Are some of these benefits, are they adding on to each other? Are they incrementally adding to each other? If you have multiple factors, are they multiplying one another? It's hard to know, but this is kind of the sort of prevailing idea with all of these anecdotal benefits out there. It's just very tricky to sort of tease those out in controlled studies. And you can't have a lecture like this talking about patients with disability without getting into all of the medical considerations. By no means is this an exhaustive list. When you're talking about a impaired population, those with disabilities, you're generally talking about an older type of population. They have a lot of premorbid medical conditions. They may have medical conditions that potentially can affect how they will respond to scuba therapy. And so it's a very sort of critical thought process to think about, is it safe for someone to go through this type of therapy? Things like osteoporosis, are they more prone to fractures? Have they had fractures? Atrophy, do they have certain muscular atrophy because they no longer have use of the muscles? Is the equipment going to fit them properly? Do they have skin breakdown? If they're insensate, a spinal cord injury person may have large wounds or wounds that are open, potentially may not be able to get into that. So anyway, there's multiple medical things that need to be considered. I'm not going to beleaguer this, and there are different algorithms and things that the different organizations will go through to try to help determine whether it's safe or not for someone to go through that. So, right, we had the shallows of the research, now the depths are the possibilities in my mind. There's so much out there, there's so much benefit that has been seen from all of this. I tried to break down what I could, put in, what is known in the medical literature to try to help break this down and explain why some of these may be happening. Some of this has been demonstrated in the research, most of it has not. But I implore you that there's really kind of an endless sea of research out there that can be done. It's just potentially expensive, difficult to control, finding the right population, other medical considerations. There's a lot that can be done. And that actually is all. I have 4 slides of references. if anybody wants to read them, I'm glad to share those with you, or if you want specific references. This is me in Grand Cayman. Not on an adaptive diving trip, but a fun picture that I like to share. Please, yeah, I'm open for questions, comments, whatever.
You answered something very powerful in my life. I've always been attracted to water, deep water. That was what compelled me to do deep water submerged victim work for the Red Cross for 2.5 years. And I also have suffered a lot from very frequent bronchitis-like symptoms as a part of some medical issues related to my autism. And what's amazing is that I would always feel better physically when I was underwater, even during the heights of bronchitis. And my parents would always try to forbid me from going under the water when I had bronchitis, even though my body was telling me the opposite of what my parents were trying to tell me. So your research pretty much gave me the information to help me understand why my body was telling me that, and what I thought at the time was just teenage rebellion was really my body trying to help itself.
Sure, sure. And it's interesting when you talk about vital capacity, pulmonary function. Nobody's really studied the longevity of how long these benefits last for. Is it relatively short term? It's hard to know. And thank you for sharing that with us. I will say it's always I'll say pulmonary function is one of those medical considerations, and so just making sure that whatever you're doing is that you're doing safe and whatnot, and not having any type of infection, anything like that. Of course.
But see, the thing was this was not actual viral bronchitis. This was the product of autoimmune stuff that people with autism can have. So that's why the benefit was coming up, because my parents thought it was bronchitis and it wasn't. So
very interesting. Right, it does allow the lungs to expand more than potentially they are on land. Yeah, please.
What tools and methods have you used to collect the data?
So actually, I have not actually performed this research. This was all sifting through the existing literature that is out there. I have worked with rodents for other purposes, not specifically related to this. I have worked with Army soldiers looking at physiology, thermal regulation, things of that nature. Nothing specific with hyperbaric oxygen, or these populations. It's something that I'll say from a personal standpoint. I've always been interested in scuba diving and end up getting my rescue certification, and then now it's kind of coming full circle with my medical career. But going forward, after finishing my training, I plan to get involved in more direct research.
Can you share your resources later?
Absolutely. Yeah, the references? Yeah, absolutely. No problem. Sir?
In terms of some of the pain issues and some of the other dynamics, weightlessness is the environment that we spend our time in, as far as that's concerned. Do we consider that as a component of some of the benefits of pain, of decreased problems with your breathing, where you have less gravity working on you, so you these are therapeutic also in terms of
I absolutely agree.
All the things that you're going to build into the benefits of scuba diving for someone with disabilities. We know that there are benefits for people who don't have disabilities, but do they kind of magnify more so for people who may have disabilities?
I don't know the answer. Yeah, I think it's very possible, plausible. I think it also depends on the condition that someone may have.
Just anecdotally, we talked to a lot of folks that have disc herniations at various points in their back. They're not truly disabled, but they have chronic pain. And they talk about when they're in the water, neutrally buoyant, you've reduced that axial loading on the spine. So, yeah, that's part of the mechanism. Dr. Goodman's absolutely correct, and so are you. That's part of that mechanism.
Very good. Thank you for sharing.
You're welcome.
Please.
So you mentioned this, even to say an obvious and wide potential for research, but who's out there and who's actually chasing that mouse right now?
That is a great question. I'm not sure I know the full scope of who's out there.
I had heard something to the effect like somewhere back east, one thing but also maybe some military investigations there, so I was curious.
Right, and please, yeah.
So at the beginning, I introduced that we try to help facilitate. We have started getting researchers who've heard about us, I just had someone recently say, hey, we're doing a study, could you share this with your population? And that's what our intention is to do. So we not only want to encourage people to do the research and the hard science and hopefully get there and move us beyond anecdotal stories, but we're going to be we're promoting that. So keep with us on Facebook, keep with us, because it's going to be the people that we work with, the people with disabilities, who are willing to work with these researchers so that we can get those answers.
I'd like to make an inside joke. I heard this gentleman here from RIC. I didn't catch that, but anyway, I was in 4 different research studies at RIC, on the unofficial RIC research rat.
There you go.
I'm in training at RIC right now. Yes.
I've heard of it. Had to do with rats and stuff like that. They were using Lexapro, and I thought it had to do with serotonin. It was very interesting. So anyway, it's fascinating.
So yeah,
Who's up to it, and what do they need? I'll be the first one in the water.
So yeah, keep your eyes and ears open, because we do promote that when a researcher comes and asks for our assistance. And actually, our next presenter is going to be someone that we worked with on getting some research done. So
Very good.
thank you.
Thank you. You're welcome.
Start again.